Good morning. My name is Dr. Phil Brotman, and I'll be speaking with you today about emergency medicine, and for Part 2, CK for USMLE. Emergency medicine consists of many topics, including cardiac resuscitation and the treatment of poisoning and other environmental accidents and injuries. First, in this chapter, I'd like to go over cardiac resuscitation. Cardiac resuscitation consists of two separate subcategories. The first is basic life support, also known as cardiopulmonary resuscitation. And the second is advanced cardiac life support with the treatment of various arrhythmias. In emergency medicine, there is a central dogma, a central mantra, if you will. And we all know what that is. It's airway, breathing, circulation. Without fixing the airway, it doesn't make much sense to try to fix someone's circulation, because without airway, there's no life. Similarly, if someone has a very good airway, but they're not breathing at all, it doesn't make sense to give medication to raise the blood pressure or fix the circulation. Breathing's the next most important step. And then finally, circulation. Circulation usually consists of increasing the fluid volume of the patient, so there's enough circulating blood volume, as well as contractility of the heart to push the blood around the body. Okay? So the central dogma, airway, breathing, circulation, works most of the time in emergency medicine. And in fact, you should be thinking about this in every patient you see. Okay? We're going to see that there's a few little exceptions to this central rule. All rules are made to be broken. And I will explain those to you in detail. So let's start for a minute and talk about the airway. What are the different types of airways? Okay? What are the different airway maneuvers that are possible? So I assess the patient's airway by simply saying hello. If the patient can say hello back to me, then I know the patient has a patent airway and is breathing as well. Patent means open. Okay? Patients with a non-open airway, a completely blocked airway, may present with the universal choking sign. They will be trying to speak, but they will not be making any sound because there's no air moving through the vocal cords, right? This is a person that needs obvious intervention right away, not an X-ray. The next best thing to do if you're on the street or the ER or the hospital would be Heimlich maneuver, followed by laying the patient down and removing the foreign body by techniques we'll discuss. If there's any question about the airway being a problem, the first technique to consider is the head tilt chin lift method. So if you come across someone that's unconscious and their airway is poor, meaning there's no air moving, or perhaps they have snoring respiration. Snoring means a partially occluded airway. The technique is to simply put one hand under the back of the neck, tilt the head back, and lift the chin forward. That's called the head tilt chin lift method, and that may open the airway. This technique would be contraindicated if you suspect a cervical spine fracture, wouldn't it? You don't want to open someone's airway but make them paraplegic, quadriplegic for the rest of their life. So if there's any suspicion that there's trauma involved, any suspicion at all, or any injury above the clavicle, it's best to use the jaw thrust maneuver to open the airway. The jaw thrust maneuver, I don't need to extend or flex the neck at all. I simply put my fingers behind the jaw and push forward, anterior, and that will open the airway. The snoring would go away if the patient was snoring, or the patient would be able to then have an open airway and start to breathe. You notice that these first two maneuvers, the only tools you need are your hands. That's because opening the airway is so critically important that you use these techniques first, and then after that we go and get our plastic tubes to keep the airway open. Okay? Of course, the next thing to do is to evaluate the patient and see if there's anything in the mouth or throat that's blocking the flow of air. Vomitus, dentures, blood are all common findings. For this, you would use suction or McGill forceps as needed to remove the foreign matter from the mouth and throat. Okay? There are two types of airway adjuncts short of intubation. They are the oral airway and the nasopharyngeal airway. The oral airway goes in the mouth, and this is what you commonly see the anesthesiologist use in the operating room. This keeps the tongue from falling back and closing off the airway. Okay? The main thing to remember with the oral airway is that it is never for awake patients. It is never for patients who have a gag reflex. They would be awake, right? If you do that, the patients are going to gag and vomit and aspirate and not do well. So this is best used with general anesthesia. It is best used in patients who you've thoroughly examined and you know that they have no gag reflex and they're not likely to have a gag reflex soon. The second type of airway adjunct, short of intubation, is the nasopharyngeal airway. The nasopharyngeal airway is placed through the nose, goes through the back of the throat, and holds the airway open. The nasopharyngeal airway can be used in patients under general anesthesia as well as patients that are awake. So this is for asleep and awake patients. It can be used in patients that have a gag, that are just have kind of snoring respirations. Okay? What do you think the contraindications to a nasopharyngeal airway is? Well, the main problem with this is it can cause epistaxis. It can cause bleeding. So you have to lubricate up the tube with some lubricant and gently place it. Okay? So if I had a patient who had a very high INR, or had a was on Coumadin, I would be very reticent to use this device because I don't want to start bleeding from the nose. Okay. The ultimate form of airway, which we're all thinking about, I know you've been thinking about it, is the endotracheal intubation. This is the definitive airway, the most secure airway. And this is the plastic tube that's placed usually through the mouth. You can place it through the nose as well. And then the tip of the endotracheal tube ends up below the vocal cords in the trachea. And the advantage of this is that there is a little balloon which you inflate inside the trachea. And this helps prevent any aspiration down around the outside of the tube into the lungs. Right? Okay. Of course, endotracheal intubation comes with some costs. You have to give the patient should not be awake during this procedure, and you'll need to sedate and essentially do anesthesia on a patient to put the endotracheal tube. And of course, in the emergency setting, our patients are unknown if they have a full stomach or not, and you have to be very careful not to induce vomiting and aspiration. Okay. So, in other words, if you come across someone not breathing, your first step is not endotracheal intubation. If they ask you the question, patient needs an airway, what's your first step? Your answer is head, tilt, chin lift, or jaw thrust. Okay? When then the airway's open, you're happy, then you go ahead and you can either put an oral pharyngeal airway, a nasopharyngeal airway, or you could do endotracheal intubation. Okay? Let's take the case now of a patient where you were unable to get an airway with any of the techniques we've just discussed. Okay? No matter what you do, you can't get the airway open. There's some tumor, there's laryngeal edema from anaphylaxis, there's a piece of hot dog in the throat you can't get out. For whatever reason, you can't open the airway. You know, you got to fix this now. The patient's only got a couple minutes left. You know, after 4 minutes, there's brain damage, right? Okay. So that's when you do the cricothyrotomy. Cricothyrotomy involves taking a scalpel, or there is a needle technique, and puncturing the cricothyroid membrane. Did you feel it there? Put your finger up on your neck. Feel where the Adam's apple is? That's the thyroid cartilage. Move down, and you feel that little notch there. That's the cricothyroid membrane. So the good thing about step 2 is you don't have to show the board that you have the psychomotor skills to do this. You just have to know when it's indicated. And it's indicated when you can't get any other airway. All right? Now, when is cricothyroidotomy relatively contraindicated? And you'll read, and it's correct in children. Okay, some people use the cutoff of age 12. I think it's really the size of the patient that matters. You could have some very big 12-year-olds, and then you wouldn't hesitate. Okay? Okay, so in small people, in pediatrics, this technique doesn't work and is contraindicated. So you're going to ask me, what do you do if you have a child and you can't get an airway? And in that particular patient, you do needle jet ventilation. And basically there, you just take a 12-gauge angiocath and stick it through the cricothyroid membrane, remove the needle, and then attached to that end of that angiocath, you can put the end of number 3 endotracheal tube adapter, and then you can ventilate the patient through that. That's a little extra information. They're not going to ask you a test question about the size of the angiocath in pediatrics, but I thought I should explain to you what you do for kids. Okay? Okay, so there you have the airway. You'll notice that in the discussion of the airway, I did not once talk about an AMBU bag, or a ventilator machine. Those devices are for the next step of breathing. Okay? All right, so let's take a case, and maybe it'll bring it more to light. Let's say you are working in the emergency room, the question says, and you should know that if you're in the emergency room setting, you are responsible for the actions of the paramedics, the firemen who are out in the field. And you are in radio communication with them to tell them what to do. And, you know, if the radio breaks, they have protocols to follow. But generally, you're responsible for telling them what to do. Okay. They have on their ambulance pretty much the same equipment that you have in your emergency room, in your hospital. Okay? So let's say you have an 18-year-old male that they call you, and they found this person unconscious on the street with a needle in his arm. All right? They give you the respiratory rate is 8 and shallow and snoring. Remember, snoring means partial airway obstruction. Okay? Patient is cyanotic, he's blue. Blood pressure is low, 80/60. Heart rate is 50 and falling. Ooh. Okay? What do you tell the paramedics to do first? Okay? Okay? So, you know, we all know what the diagnosis is. This guy's got what? He's injecting heroin. It's a narcotic overdose. I know that the way to wake him up, the most efficacious treatment, is to give him Narcan and he'll wake up. But you know what? It's going to take a few minutes to start the IV, draw up the Narcan with the syringe. And if I wait that long to give the Narcan, by that time he's going to have no pulse, no breathing at all. So I need to do the airway first. So the answer is not number A, start IV and give Narcan. That's not the first thing. Giving oxygen, well, that's fine, but if the oxygen's not getting into the lungs, that's not going to help you, so we'll do that a little bit later. C is also wrong. I'm not going to do bag valve mask ventilation. That's a breathing technique. I have to establish the airway first. Remember, he's snoring, partial airway obstruction. Okay? Am I going to do the choice D, intubate the patient? Of course not. I don't do that first in airway management. I'm going to do a jaw thrust or a head tilt chin lift, right? Okay. When I do that, the snoring abates, and he's breathing normally. At that point, if he's breathing normally on his own but just holding the airway open, I don't have to breathe for him at all. And the other paramedic, they always go in pairs. That's why there's a paramedics. He could start the IV, and sorry about that, and give the Narcan. At that point, the patient will wake up. You can release the jaw thrust, and the patient's crisis is over. Let's take a slightly different case to start to introduce some concepts of basic life support. It's basically the same guy. He's an 18-year-old on the street, unconscious, needle in the arm, same vital signs, same snoring. But this time you're walking down the street, and you see this guy. And you're walking to your board exam, and you're late. Okay? The question is, what do you do as you pass this guy on the street? Okay? It's the same choices. And do you open his airway? Do you intubate? Well, you don't have any equipment. Start IV, you don't have any equipment. As you leaning down to look at this man, and you say, hey, are you okay? And you realize that he has snoring respirations. As you kneel down to do a jaw thrust and open his airway, you will look around the street and see if anyone else is available. And if no one's there to go for help, you will scream, help, help, we need help, right? Because even if you open his airway, you cannot definitively manage this patient. To kneel down, open his airway, and stand there for 30 minutes waiting for help to come isn't really in anyone's best interest. So if you're by yourself and you see someone with a crisis, the answer is send someone for help, go get help. Okay? Then open the man's airway and wait for help to arrive. Okay, let's go on to breathing. Okay? Here's the prototypical breathing case on board questions. All right? A 30-year-old with severe life-threatening asthma is getting tired. When they say getting tired on questions, they mean that her PCO2 is starting to climb. She's getting a little somnolent from her hypoventilation and elevated PCO2. Okay? In her groggy state, she tells you that she doesn't want to ever be intubated again because the last time she was intubated for her severe asthma, she wasn't sedated adequately and she had that terrible suffocating choking feeling that patients get who have endotracheal intubation that aren't properly medicated. She says, just let me die. Okay, so here are the choices. Do you make her do not resuscitate, do not intubate, and let her die? I mean, patient autonomy is important. Okay? I should tell you she's got 2 small kids at home, right? Not a good choice. Do you do B? Do you explain to her that you will keep her unconscious and sedated with medication while she's on the breathing machine so that it won't be a painful and horrific experience like last time? That's the answer. That's a great answer. Okay? You might also see an answer on some of these test questions. A newer technique is called non-invasive face mask ventilation. Okay? Traditionally, patients that have endotracheal tubes can be ventilated by 2 methods. One with the bag valve mask, right? And that gets kind of tiring for the respiratory therapist. So you take the bag valve mask off and you hook it up to a machine with the bellows, right, of the ventilator. Okay? What non-invasive face mask ventilation is, it's the use of the ventilator without the endotracheal tube. So in other words, there's a tight-fitting mask on the face of the patient, like a jet fighter pilot, hooked up to the ventilator, pushing the good air in, so to speak. Okay? So the patients can be ventilated without being intubated. For this technique, though, the patients do have to be awake. You don't want to take an unconscious patient and put a face mask on and hook them up to a ventilator, because they won't be able to hold their airway open. They won't have a gag reflex. The air will go into the esophagus, it'll make them vomit, and then they'll aspirate. So the non-invasive face mask, meaning no intubation, is just for patients who are awake. That would be an option for Our Lady here. Okay, so let's go over the indications review for intubation and ventilation. 1, the ultimate technique for protecting the airway from vomit and obstruction. The only thing better is to be awake and breathing on your own and hold your own airway open on your own, okay? It's to facilitate positive pressure ventilation. It makes it easier to hook them up to the machine than to stand there with an ambu bag and a face mask for hours ventilating the patient, right? Right. Patients that need breathing, the sequence of events are, after you do the airway, then you put the ambu bag on and you breathe for the patient while you're setting up for the ventilator, okay? So these are done sequentially. So in other words, if this seems confusing at all, the ambu bag can be used with a face mask just on the patient's face, or the ambu bag can be hooked up to the endotracheal tube that's already in place to help ventilate the patient. Then you wait for the ventilator to come down, you hook the ventilator up, and you take away the bag part of the ambu bag. All right. Next is circulation, okay? A, B, C, circulation. So until I fix A and B, as a general rule, we don't do too much with circulation, except I'll show you the exception in a moment. Circulation consists of 2 basic components, all right? There's the circulating oxygen carrying capacity. That's the blood volume, how much liquid and how much hemoglobin, right? And there's the heart pump. There's the contractility. The heart rate has to be adequate to push the blood around the body, okay? So I want you to think now of the case of anyone with blood loss who has a problem with circulation. This goes for any age, 1 day to 99 years old, and it goes from blood loss, from acute blood loss from any cause. It can be from trauma, it could be from a medical condition, it could be GI bleeding, the blood can be dripping on the street, the blood could be internal bleeding, it doesn't matter. They're going to tell you in the first part of the question, they're going to give you some clues that the patient's getting shocky. They're going to tell you that the skin is cool and clammy, all right? They're going to tell you that the patient has delayed capillary refill, all right? Patient's going to be anxious typically. Anyone that's hypoxic gets anxious. So you see the anxious patient, the first thing you don't think is psychiatric. You think, hey, I wonder if they're hypoxic. If looking at the patient's color is an option, that's a good thing to do. If taking a pulse oximetry reading is a choice, that's a good thing to do. Okay, and we all know as you lose blood, your heart rate goes up and your blood pressure goes down. This patient's heart rate 125, blood pressure 80 over 60. Okay, breathing a little fast, respiratory rate 24. All right, so if they say, what do you want to give, what do you want to do next? And these are the choices. The answer is give IV fluid, all right? That's the answer. That's the first thing you do. That's what's immediately available, and it's quick, and oftentimes that's all the patient needs, okay? What fluid do you give? Well, you can give 0.9 normal saline, or you can give lactated ringers, okay? For fluid resuscitation for blood loss from a trauma or bleeding from a medical cause, do not resuscitate the patient with D5 normal saline. Do not resuscitate the patient with D5 water. Even if it's an 80-year-old person with a bad heart who has a massive GI hemorrhage, you don't use D5 water to resuscitate this person. You use normal saline, okay? When do you give blood? Okay? The wrong answer for this question is, well, I'm going to check the CBC and make sure that the hemoglobin is 10. In fact, people with very acute brisk bleeding, if you take a tube of blood out of their arm, the hematocrit's going to be whatever their baseline is. And until you give some time for the body to equilibrate and replace the lost liquid with IV fluid, it will be only then that you'll see that the patient has a low hematocrit. So this is a clinical diagnosis when they need blood for severe hemorrhage. Okay? As a rule, we go ahead and we do type and cross for packed red blood cells, right? There's very little whole blood available to give to patients anymore, right? The serum's taken off, and a unit of packed red blood cells is mostly cells, not that much liquid. Okay? Under what circumstances do we give O-negative blood? O-negative is the universal donor. Okay? When do we give O-negative packed red blood cells? And the answer is when we think the patient's going to die from blood loss, from hemorrhage, prior to the typed and crossed blood being ready, right? Because O-negative blood, they just take it off the shelf and give it to the patient. Typed and crossed blood, you have to get a sample from your patient. It has to go to the lab. They have to cross-match it from one of the donor units of blood that someone donated and then give it to you. That takes 45 minutes on a good day, right? Okay. After you resuscitate your patient with IV fluids and or blood, you're going to monitor the patient. And how do you do that? Well, you follow their vital signs. Heart rate's going to go down, blood pressure's going to come up, capillary refill's going to get better, they're not going to be cool and clammy, they're going to be less anxious, their mental status will be normal. Okay? That's how you tell acutely. It takes time to measure the urinary output. Yes, you want to measure the urinary output to determine if the fluid resuscitation is adequate. But to measure the urine output, I have to put the Foley in, empty the Foley, then I have to wait 30 minutes to see how much urine they've made in the last half hour. Well, that's too long to leave someone in hypovolemic shock, isn't it? So that is a secondary measure, urinary output, to measure the adequacy of their resuscitation. All right. You know, A, B, C, airway, breathing, circulation. C is also for C-spine. Doesn't do a lot of good to take care of the circulation if you move their neck around and now they're quadriplegic. The prototypical case on this is someone that dove into a pool and there's no water in it and they land head first. All right? This patient, let's take this case here. He's breathing spontaneously and shallowing, but a little bit shallowy. There's no snoring. And you know what? You go up to him and he's talking normally. He says, oh, my neck hurts. My neck hurts. I can't move my legs. Maybe I can move my hands just a little. I can't move my legs. Oh, there's no water in the pool. So you know a lot about this guy. His airway is good. He's talking to you. His breathing's good. He's talking to you. And you know what? His circulation, even before I touch him, I know is probably pretty good. He's talking to you. There's adequate perfusion of his brain that he's able to think and talk. All right, vital signs, 100/60, a little low, most likely. 120 heart rate, 12 respirations, no snoring. So in this particular guy, what were we all worried about? Could he have a little subdural hematoma which is expanding? Sure. Could he have other associated injuries such as a broken bone or perhaps some thoracoabdominal trauma? Absolutely. But the main thing we're all suspicious of is that he got a cervical spine injury with an injury to his spinal cord, right? Okay. But before we even get to that, we're going to review his airways. What do we need for his airway? Do we need to do intubation because he might lose his airway later? Should we place an oropharyngeal airway? The answer is no, because he's awake. Do we turn the patient on his side to prevent aspiration? The answer is no. We're worried about his neck. Okay? Do we place a nasopharyngeal airway in an awake patient? You know, the first response to nasopharyngeal airway in an awake patient is patients do this. So we don't want this guy turning his head, right? Okay? His airway's fine. He's breathing. He's not snoring. He's talking to you. The answer is E, do nothing. If it changes, if he starts to get sleepy and somnolent and snore, well, then I could do the jaw thrust and consider other airway techniques. What about his breathing? Here are the choices. Do nothing, give oxygen, put the face mask on and do ambu bag. Do I want to palpate his trachea, chest wall, and listen to his lungs? That would be choice D. Do I want to do bilateral needle decompression of his chest? What do you think? All right, well, you know, A, if I do A, I don't assess to look for any other associated injuries, so that's not the right choice. Giving oxygen, that's not an unreasonable thing to do, but there's a better choice first on this list. C, he doesn't need any help breathing. The bag valve mask is for breathing, so I'm not going to do that. E is also wrong because he doesn't have a pneumothorax. Okay? But how would I look for a pneumothorax clinically? I would palpate the trachea. I would palpate the chest wall. I'd feel for crepitus when he breathes, and I'd auscultate the lungs. So that's the right answer here. That's what I'm going to do next for his breathing. He's breathing okay. I really don't need to do any maneuvers, but I'm going to assess for any other types of injuries that will affect his respiratory mechanics. Okay? If I found that his trachea was pushed to the side, to the left, let's say, and he had no breath sounds on the right, and he was turning blue and cyanotic, and his blood pressure was dropping in front of me, well, then I would know he would have a tension pneumothorax on the right from his injury, and that's when I would do the needle decompression of the chest. All right, what do you want to do about this man's with a broken neck circulation? Okay, what's the first thing? Do you want to give some IV fluid? You know, spinal shock, increased capacitance of the venous blood vessels, all that. Okay? What's the most important next thing to do? His blood pressure is stable for the moment. So the next thing I would do is stabilize his neck. Okay? So the answer is A. Stabilize the neck first. Then you can give a little bit of IV fluid. Once he gets to the hospital, the question for the broken neck case might read something like, these are the choices. What do you want to do next? And then they're going to take you through your question and ask, what do you want to do after that, and after that, and after that? So here are the choices. Do you want to give IV Solu-Medrol? The answer is yes, eventually. It's not the very, 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 very first step. Solu-Medrol or corticosteroids are good for spinal trauma. They are not for brain trauma. Yeah, I know, it's confusing. They're both central nervous system, but steroids work for spinal cord trauma. For cord trauma, they do not work and are contraindicated for brain. Okay? All right. So we're going to give steroids to this guy, but there's a better choice what to do first here. B, maintain proper neck alignment. Yeah, that's what I want to do, right? I want to give him a collar to wear so he can't turn his neck with respect to his shoulders. I want to put him on a backboard, piece of plywood essentially. I want to put sandbags on the side of his head. I could tape his forehead to the board. I could tape his hips to the board. That way, if he gets nauseous and vomits, all I have to do is pick up the board, and the whole patient will move like that, and his neck won't move relative to the rest of his body, but I could still turn him on his side, so when he vomits, he won't aspirate. Okay. Do I want to do a neuro exam? Sure. Call the neurosurgeon? Sure. Order x-rays, CAT scans of the neck and head? Sure. Okay. So the first thing on this is going to be to maintain proper alignment. All right? Okay. Then you're going to, in any order, particularly, you can give the Solu-Medrol next. You're going to order the x-ray. You're going to do a thorough physical exam. You're going to call the neurosurgeon, right? And your thorough exam will include working up any other medical problems the patient has. Okay? If someone has a neck fracture, we're not going to physically, put your foot up on the shoulder and pull. and try to reduce the fracture yourself. If it's a fracture dislocation of the spine, that's the job of the neurosurgeon. It's out of the scope of step 2. If you recognize the word Gardner-Wells tongs, choice F here, that's the technique why they slowly distract the bones of the neck and get them back in good alignment if these are vertebral bodies. Gardner-Wells tongs are those metal screws that go into the side of the head, and then they put a metal halo on, and from the back of the halo they hang weights on traction and slowly distracts the neck back into place. So here's the rundown, the way it would really go to treat this patient with the broken neck. He gets to the emergency room, you do A, B, C. You mobilize his neck, you make sure and reassess that airway, breathing are intact. He gets IV fluid, he gets oxygen, he gets pulse oximetry, he gets cardiac monitor, right? You send off your blood tests, you send off your x-rays, you send off your requests for the steroids. Don't forget to give the patient pain medicine, right? And you get the neurosurgeon off the golf course. Let's talk now about basic life support, BLS, CPR, cardiopulmonary resuscitation. How and when do you initiate all of that? All right? The case is a man is found kind of slumped over a little bit in his chair at the symphony. His eyes are closed. Does he need basic life support? All right? You only need basic life support if you're dead. This guy could just be sleeping. It might be a dull show, right? Maybe he's breathing and has a pulse, but maybe he's just unconscious. Maybe he's postictal. Maybe he has hypoglycemia and is unconscious from that. All right? So the first thing we do when we see someone who looks like they might be sick, the most important thing you need to remember is you need to go check out the scene. You need to go be a good Samaritan. You need to be caring and go look at the patient, right? So you go over to him, and what do? Do I start by doing chest compressions? No. You say, hello, and give him a gentle shake, right? All the CPR dowels where you learn how to do CPR, they're called anti-dowels. So if you take a formal CPR class, which you don't need to pass Step 2 CS, I'm giving you the information you need right here. We used to train you and go, Annie, are you okay? And shake the pretend Annie dowel. So if you do take the class, it's kind of fun because when you actually come upon a real dead person on the street that needs CPR, you find yourself reverting back to your training, and you go up to the person, even if it's a man, shake them, Annie, are you okay? All right, so in other words, you have to establish that they're unresponsive. Hello, sir? Anything like that. Maybe they just wake up and they'll go, oh, yeah, boring show tonight. All right? After you do that, and you find that they're unresponsive, I know that we all want to do the airway. We want to do the airway. We want so badly to do the airway. But for basic life support, there is a step before the airway, and that step is get help, right? Try this out. Repeat after me. Help! Call 911. I can't hear you, right? You need help. Because if this man is really dead, the most common arrest rhythm we'll discuss is ventricular fibrillation. If I just slow down there and I open his airway, he's still in ventricular fibrillation. And if I'm there by myself in this room with this dead person with the open airway, he's not going to get better until I get help, right? If you're in a public place, I suggest you scream, help, call 911, get the AED. AED stands for Automatic External Defibrillator. These are the devices you see in the airports, and basically what they are is they have two big sticky pads. Like one goes on the chest, one goes on the back, and you press the start button, and it automatically analyzes the patient's heart rhythm and defibrillates if the patient needs it. All the applicator, all the person needs to do to initiate this is hit the start button. The machine does the rest. Okay? So I know it's counterintuitive to get help first, but why is it so important? Well, it's important because if the patient isn't returned to a perfusable rhythm soon, they're going to be permanently dead. The most common arrest rhythm, that means patients with no pulse, or cardiac arrest, no pulse, no breathing. The most common arrest rhythm is ventricular fibrillation. And the mortality rate is approximately 10% per minute. So if you open the airway and even do CPR, and you are not getting any help, no one's bringing a defibrillator, you can hold the airway open for 10 minutes, and then essentially there is zero chance of this patient ever recovering. Okay? Okay? So here we have an exception to the ABC rule. We should really say it's get help, ABC. So here we have a complete review of the airway issues, right? This should be review now. This man's there. I've called for help. I've laid him down, got him off the chair. He's unresponsive, all right? And I don't see any breathing. I've looked, listen, and feel. What you can do is you can put your ear over his nose and mouth, and if he's breathing, you'll hear the breath. You'll feel the breath on the side of your face, and I'm looking down his chest to see if the chest is expanding. And this guy, nothing's going on. So if that's the case, I'm going to start my airway maneuvers, and if I'm in the opera house, all I got with me are my hands, and even if I was in the ER, in the clinic, the first maneuver is a head tilt chin lift or a jaw thrust. Okay? Once help comes, when I get suction, I can do suction. Once I get my other equipment, then later on in the resuscitation, I could do the oral pharyngeal, the nasal pharyngeal airway, intubation if needed. Okay, cricothyrotomy if all else fails. Now, BLS, basic life support, consists of, after activating the emergency medical system, that's calling 911, calling for the paramedics. I see that they're not breathing. I do the 2 rescue breaths. Keep their airway open, pinch their nose, give the 2 breaths. The chest should rise, the air should go down and back out. Then the next step is to do what? Check the pulse. All right. How long should you check the pulse for? The answer is not very long. All right? Seconds. A few seconds. If there's no pulse, then I'm going to begin chest compressions. If there is a pulse and the patient's not breathing, which can happen for a little while anyway, in that case, I will continue to give the rescue breaths every few seconds, 10 a minute. Okay? But they would not need any chest compressions because they have a pulse. Okay? If there's no pulse, I'm going to start chest compressions. And, you know, when you're in the situation, it's a little bit of a stressful situation. And even for the test questions now, the Heart Association has given us the guidelines of push hard and push fast. That's the answer. That's the answer. Push hard and push fast. That's going to be about 100 compressions per minute. And the key issue is to remember to let the chest recoil all the way. If I push down on the sternum and never release, I'm not going to move any blood around the body. All right? What's the ratio of compressions to the breath? They're de-emphasizing this a little bit, but the rule is that if you're by yourself with a single rescuer, it's 30 compressions to 2 breaths. And if you're doing 2 people CPR, you can do 15 compressions to 2 breaths. All right. So here's the main algorithm, and this is what to remember. All right. You go up. You see someone who looks like they might be in distress. You go up to them and give them a little gentle shake. Hey, hello. How are you? If they wake up, you're done. If they don't wake up, if they're unresponsive, you get help. Help! Call 911. Get the AED. Okay? If you are in a room and you can actually point to someone and say, you, call 911 and actually assign the task, that's great, that's even better. Next, I open the airway, all right? By the jaw thrust or the chin lift, head tilt chin lift technique. Then I check for breathing, right? If they're not breathing, what do I do next? I give the 2 breaths, right? Then what happens? Now I check for pulse. There's no pulse, I begin my chest compressions, okay? Now, what do I do when a defibrillator arrives, an automatic external defibrillator arrives? As soon as that's on the scene, that is your top priority to put that on and press the start button, and that machine will determine if the patient needs defibrillation and will be life-saving if the patient's in VFib. CPR, chest compressions, does not cure ventricular fibrillation. That's why the AED is so important. So let's take the next case. Now we're at the symphony. We've left the opera, we've gone to the symphony. There's another person there who's unresponsive. So you've studying for your step 2, you go over there and you assess the situation and you say, sir, are you okay? And he's unresponsive, all right, drool's coming out the side of his mouth. So even though it's during the prelude of the symphony, you scream, help! I need help, call 911, get the AED. Okay, 18 people you see take out their cell phones, and so you immediately lean down and open his airway. And you start, no breaths, patient's not breathing spontaneously, you start breathing for him, okay? You're doing chest compressions, that's fine. Now the next question will be worded something like this. I'm going to make it kind of silly, but it's kind of fun. Simultaneously, an anesthesiologist shows up, he's at the symphony, and he happens to have his laryngoscope and his endotracheal tube with him. And he says, let me intubate. I can intubate, I'm an anesthesiologist. And at the same time, the usher from the symphony brings you the AED, the automatic external defibrillator. You're taking charge of the situation, or you're answering the test question, and they say, what happens next? The intubation or the defibrillation? What is going to promote the person's survival the most is the correct answer. And the answer is defibrillation. Put on the AED, okay? That's your top priority. Now, if you could do both at the same time and not delay the defibrillation even 1 millisecond, that's fine, you can do both. But you know what? That's not the real world. Put the AED on, okay? If the patient's not breathing for 90 seconds, that won't kill him. If you delay defibrillation by 90 seconds, you decreased his chance of survival by 15%. So put on the AED, all right? Because VFib is the most common arrest rhythm. The CPR is not going to cure VFib. Putting an airway is not going to cure VFib. You need electricity. That means shock. I'm going to use the word electricity and shock interchangeably. You need electricity or a shock to survive. Now what's going to happen if this man went into cardiac arrest right before you shook him is the AED will be placed. It'll recognize the VFib. It'll shock the patient. The patient will begin to have a pulse and will start breathing spontaneously. And the patient will wake up and even be groggy by the time the paramedics get there, and he might not ever be intubated. So here is a situation now where I'm doing C. I'm doing defibrillation, which is part of getting your circulation going, getting your heart restarted before I'm doing the airway. This is one exception to the ABC rule, the most important one. That is the end of basic life support.